Dr. Samir Keole, welcome to the show.
Hey, Chadi, thanks for having me.
I'm really excited to have you and overdue. I'm a big fan, of course. Wanted to have you for a long time on the show. Always like to have presidents on the show, you know? I mean, you're apparently some kind of a president.
I don't know how that happened, but yeah, I guess I'm technically the president of the American Society for Radiation Oncology, which most people just refer to as ASTRO.
Well, very delighted to have you, and we'll talk about your role and what Astro is doing and under your leadership. But a bit about you. Tell us a little bit about you, Samir. Just, what you do and your career path until you became president of Astro.
I've had a pretty unconventional career path. So, like probably a lot of teenagers, didn't know what I was going to do. Circled around a bit, ended up obviously going to, doing medical school, and had a look at all of us, right? We have mentors, and so happened to I grew up with a guy named Nitin Vaishampayan. Now he was older than me by 6 years, so he was more like a big brother. But I was I had an elective month open. And so I ended up spending a month with him. He had just finished up training and was in his first attending job. And believe it or not, I was going to go into OBGYN or ER medicine prior to this. But I always liked technology, but I wanted to face patients. And I spent the month with him, and it all kind of clicked. There was the physics and the math and the technical and the that aspect to radiation oncology, but then we were interfacing with patients and making them better. And I thought really making a difference. And so it kind of clicked at that point. And so I kind of redirected myself, decided to apply only for radiation oncology. So that would have been in the late 90s. And I graduated med school in 99 and then ended up at Wayne State. And he then finished in '04. So I've been out. This is, I guess, my 22nd year of practice.
Oh, amazing. So when you do radiation oncology, Samir, do you need to subspecialize? Have you become in academic world similar to medical oncology where you take care only of the lower pole of the right kidney?
We do. Well, Mayo's famous for that, and we do have some of that. We're not probably quite as specialized here as, say, I'm in Arizona, so not quite as specialized as maybe they would be in Rochester. The Rochester department, to put in perspective, has about 45 radiation oncologists. We have about 16. And for context, there's about 5,000 radiation oncologists in the country. But no, you don't have to. And in fact, the majority of our members are what I call generalists. And so after it's 1+4, it's a total of 5 years. So we're the only residency, actually, if you think about it, that leads into oncology. Everybody else is a fellowship, right? You're a fellow. You did
Right.
fellowship, surgical oncologist, urologic oncologist. You can actually go into radiation oncology directly out of medical school. 5 years later, you're board eligible, and then you're eligible to take your boards as early as year 6 out of medical school. And when you get board certification, it's for everything. And so if I've had a circuitous route to get to Mayo. I was first at University of Florida for 5 years, and then I was in private practice in Oklahoma City for 4. And there I kind of treated everything. And then now I'm at Mayo, where it's a little more specialized of a practice.
What led you to leave private practice into more of an academic practice?
That was a tough decision. That was probably the hardest professional decision I've ever made because I wasn't running from anything. I really enjoyed being in private practice. I did enjoy the small business aspect of being my own boss, signing my own paycheck with all the headaches that come with it. I think that I was interested in that time, still am, but in proton therapy, and I thought proton therapy needed a Mayo Clinic to enter where there was no finances were divorced from trying to push it forward clinically, and I thought for that reason Mayo Clinic made a lot of sense. I almost took a job at Mayo Rochester in '08. It didn't make sense at that time for me personally or professionally, but it was not a bad thing. It just wasn't the right time. But I really, really fell in love with the concept of Mayo at that time. And so when the job presented itself a few years later, I ended up accepting it, but not initially. I got offered the job, then kind of said I wasn't sure, and I'm going around in circles here because even to this day, I was just in Oklahoma City 2 weeks ago, Chadi, and I saw my old group, and we went out to dinner, and we're all still very good friends, and it was private practice is an incredible place. Too many of our members are not going into it, but it's really amazing. But I think Mayo Clinic, especially with its values, appealed to me and was a good fit. But certainly, I could have stayed the rest of my career in Oklahoma City in private practice and been happy.
Well, I like about the fact that you're doing obviously Mayo Clinic and academic practice, you've done private practice, seeing both sides position you really well when you are, I think, a president of a society that should represent both sides, right? I mean, the community and the academia.
Yeah.
How did you land to become the president of ASTRO? Is this an appointed position, elected position? How did this happen?
Oh, great question. Thanks for asking. I think it mirrors a lot of other societies. So a lot of it is just showing up, right? And as somebody said to me once, you volunteer for these jobs, right? And maybe the first job is kind of crappy, and you just do it. And then next job you're assigned maybe isn't so bad and isn't quite as crappy. And the next thing you know, you start getting some pretty interesting things. So I guess again, this all comes back to mentors. And I was always interested in advocacy, even though I've published a decent amount. Could always publish more, but I've published.
Yeah.
But I was always interested in advocacy. Got involved when I was a resident, and there was an opportunity to join the government relations committee coming out of residency. This is 21 plus years ago, and so I did that, and that kind of led to I helped our society in the CPT and RUC process. For the viewers who don't know, that's current procedural terminology, and then the relative value update committee, which is how we get paid as physicians. And that coincided with my going into private practice, where that's really, Chadi, where I learned how the dollars flow. When I was in academia, I didn't understand how any of this stuff worked. And when I got into private practice, coupled with going to the RUC meetings, I recognized we really need to speak up for ourselves. So I think that gave me a unique perspective. And so then I went to Mayo, but I never really forgot those years in private practice. And so I think the fact that I've been in rank-based academia, private practice, and Mayo Clinic, which is kind of a hybrid but closer to academics, gives me the ability to identify with really most segments of our society. I think you'd asked me a little bit about the community practice aspect. I think one thing that most societies struggle with is having an adequate voice of the community. That's for a lot of reasons. I think that I used to be on the ASCO Cancer Link board, so I saw that side of things. And I've done, now this is my 6th year of service on the ASTRO board. This is an enormous time commitment. And when you're in academics, you kind of have this time set aside. But when I went into private practice and I told the group, they were very supportive, but they said, hey, look, you get 30 days a year. You can do with them whatever you want. You want to go scuba diving in the Caribbean, or you want to go and volunteer for ASTRO? That's on your time, and you do what you want. And so I do think in that sense, it's harder to get traction sometimes when you're in private practice because there's competing interests, and it's truly out of your own pocket in private practice. I don't know. Hopefully that makes sense.
Yeah, no, it does make sense, and we'll come back to that. But I'm still
Yeah.
curious, did you run for the ASTRO presidency? Did you
Yes.
nominate yourself? Like how's the process work
Oh, great.
to become
Yeah. So
ASTRO president?
so the ASTRO board has 17 voting seats and 3 ex officio. So 12 of the seats belong to 6 councils, and these, going in order of historic when they were set up, science, education, uh, government relations, health policy, quality, and then we have a health access and engagement council. And so these each have 2 seats, and they have a committee structure under them. So that's 12. Then we have a treasurer, which is a contested election, and then we have a presidential track. The presidential track is contested, and it you have to have basically essentially you have to have had prior board experience. And so the committee structure is where you really enter and you start volunteering. And then if you are and if you're doing the job that's asked of you, then generally you go on the board. It can be contested, it can be uncontested, but you go on the board for a 4-year term. So my first 4-year term was 2014 to 2018, and I was the government relations vice chair and then chair. Then I was off the board for 5 years and was still supporting. And then each year, the nominating committee comes around and they're looking at potential candidates for the different slate to fill out the slate. But obviously, a lot of time is spent on who's going to be president-elect. So they're typically looking at a pool of people that have had board experience and were contributors. And so I don't know if I was on the eye of people for the first 5 years because the 6th year really of eligibility. But then I did get the call saying, "Hey, we'd like you to consider running." So it was 2 of us that were put up for the ballot.
And this is a 1-year term?
Yeah, it's a 1-year term as president. It's a 4-year track. And so for us, it's probably similar to ASCO, although I don't know the exact progression. It's your first year as president-elect. Yep. And then the 2nd year, you're president. So I'm in my president year. And then you're chair of the board the 3rd year, and then you're past chair your 4th year. Yep. So I joined the board at the annual meeting in the fall of 23. And so I will rotate off entirely in the fall of 27.
So in general, whenever there's a president of a society and they get elected, they have a theme in terms of what is the theme of your presidency kind of thing. At least for ASCO, that's usually what happens, whatever that theme is. What is your theme when you assume the presidency?
That's great. We have to have a theme for the meeting, but I announced it actually in my presidential write-up from two years ago, 2 summers ago. And I guess the unofficial slogan would be going from defense to offense, but really getting ourselves to use the full scope of our training and expertise. And so the official title of the meeting, Chadi, is Rediscovering Radiation Medicine and Exploring New Indications. So look, what does this mean? Radiation medicine, there's a time when we did a lot of things in the non-malignant scope. And this is actually interesting, has been coming back in the last, I'd say, 8 to 10 years in this country, and has been more popular in Europe, especially for a few decades now. But it's the idea that you can use some of the anti-inflammatory effects, especially at low doses, to be effective against non-malignant conditions like osteoarthritis and plantar fibromas and Dupuytren's contracture. And of course, we've used it for non-malignant conditions like vestibular schwannoma. And the new indications part is, this field is exploding. And there's a lot of things. Johnny, when you and I were in training, it was pretty clear. Medical oncologists gave chemo. Radiation doctors gave radiation. Surgeons did surgery. Now you have interesting treatments like tumor treating fields. Let's use that. Anyone can really do that, right? I mean, it's anybody who touches a pancreas patient, the phase 1 data, or a brain tumor patient can theoretically do that. Our members have the ability to offer this, but I don't think many of our members do offer it. Radiopharmaceuticals is starting to come back, and I think this is a treatment that our members can offer to their patients. And so it's these types of things that we're trying to raise awareness amongst our members, saying we don't just have to sit in the basement and cure cancer 1 pixel at a time. There's a lot of other things we can do that can benefit patients. And so that's kind of the theme of my presidency and especially the theme of this meeting.
And this episode is going to be airing before your annual meeting, which is happening in San Francisco in a couple of weeks. So, what is your day-to-day life as an ASTRO president? Because you still have your own practice, you still have to you see patients, or do you actually stay on hold for like a full year? I mean,
I'm
how
on hold there
consuming?
right now. Yeah, so I work for Mayo. Actually, a couple of years ago, I transitioned into a largely administrative role where I help support our care network. But most Astro members would be practicing at least part time. Many do cut back from the clinic, so there's a personal. There's a lot of times they're making a personal sacrifice, at least in terms of income. Uh, when I was on the board in one of the 12 board seats, or at that time there were 10 board seats for the councils, uh, it was probably maybe a couple hours a week, in all honesty. Uh, Now, as president, it can be as much as 4 to 6 meetings a week. And so I always take the staff is good about scheduling them outside of my work duties. And being on the West Coast, I can do a lot of them early in the morning before I'd have to start things up. But yeah, it's I would say it can be anywhere between 4 and 8 meetings a week that I try to get on. I can't get on all of them. And there's probably at least 1 hour a night I'm spending on Astro duties. And as we get closer to the meeting, it's like sometimes 2 hours, 3 hours. So it's probably a good 8 to 10 hours a week when you average it out over the course of the year.
Did you know that, or was it surprising to you the amount of work you have to do?
I knew it was coming. I didn't quite grasp it until I was in the middle of it. But this chatty. I mean, look, when you get into this stuff, you know it's going to be work,
Yeah.
and you know it's going to be work, and you say, do I believe in it? And for me, I guess I always looked at it. Maybe it's naive, but radiation therapy, radiation medicine has been incredibly good to me, been good to my family. I've enjoyed what I've been able to do. And I said, if I can give back somehow and leave the field in a better position than when I found it, I want to help. I want to pay it forward. And so that was, really viewed it as if the electorate decides that they want to vote me in, which I'm still stunned that they did, then I'm going to do my best. And so I give it my all. But it's time.
What did you want to achieve though in your year? I know it's a 4 year thing, but
Mhm.
essentially that year when you are president is probably your most impactful year because like you're it. What did you want to see achieve? And if you do a 360 and you really self-reflect as your term as a president is ending, do you think you've accomplished what you wanted? Like, how, be your own best critic if you try to look back and say, this is what I wanted to do. A year has passed. What did I achieve? What did I wish I was able to achieve?
Oh boy, this is a well, thank you for setting me up. No, definitely
Well, that's leadership, right? You're a leader. You gotta tell us.
the answer is probably no. I'm not going to accomplish everything I set out to accomplish, but I'd like to think that I made strides in all the areas. So, Chatty, when I started, I guess I was a little bit unusual, and that's what I was told because I came in actually. One of the staff members joked it's my 1,000 points of light, but it wasn't 1,000 points. I had 8 things I wanted to get done, and I didn't know if I'd get them done. But I believed for years that uh, believe it or not, I proposed a case rate payment system back in 2009. Uh, Ideally, for your viewers who don't know, they may be surprised that we don't get paid based on an episode of care. So if someone comes to me with prostate cancer, for instance, or breast cancer, I don't get paid X number of dollars to take care of them. The more number of days you pay, they get radiated, the more fees there are. So I guess it's an analogy of a taxi versus an Uber. Um, that's never really made a ton of sense to me, in all honesty. And as we've gone more into hypofractionation, a fewer number of days for radiation therapy, which I'm sure most of your listeners will understand, this has led, it's great when it's appropriate and it's great for patients, but it's led to significant financial hardships for hospitals and freestanding centers, especially freestanding centers. So I said, we've got to get this problem fixed and we've got to address it. And so we do have legislation that's pending in Congress called the Radiation Oncology Case Rate legislation. And we're trying to get that through and move to an episodic care way to pay for cases. Then I said we need to increase our indications, and so there was a big push in the field. A lot of people were using radiation for non-malignant conditions, mostly osteoarthritis, a little bit for Dupuytren's and plantar fibromas. So we're trying to give some structure around that. We're creating some framework. We're creating guidelines, working committees, working with payers, because now there's some pushback there. There's also people that are promoting it for CNS use. This is a little more nascent, actually, for essential tremor, and that's going to be a focus of the meeting. And the last thing is this was pioneered at Washington University. They're using it for cardiac arrhythmias, medically refractory cardiac arrhythmias, and they have amazing results of these are patients who have failed every single pharmaceutical agent, and they get radiation essentially to ablate a tract, and it works. And it's working in some trials with over 80% of efficacy. So these are the kind of things that we're going to highlight in the presidential symposium. But again, getting back to the radiopharmaceuticals and the and things like tumor treating fields and even histotripsy, and trying to bring brachytherapy back. Again, give our members more things. Our members are capable of doing these things.
Yeah, no, absolutely. Samir, again, you mentioned something about community engagement. So
Yeah.
and you did say it's not easy because sometimes you have to,
Mm.
community radiation oncologists are pretty busy. Are there strategies you are trying
Yeah.
to do to increase the engagement from them?
Yeah. Thank you. And that was probably the next point I needed to get into. That was also on that list of 8. So that was one of my top priorities when I came in, is how do we get more folks from the community engaged? Now, fortunately, having worked in the community for 4 years, and I try to maintain good relationships across the country, I immediately started reaching out to folks, trying to get them to apply for committees. I think what happens, Shadi, is, again, I'm a big believer in mentorship. And I think some people are self-starters, but a lot of times if you have someone that can help you, it really can get people going. So I said I can be that person for a lot of people. So started reaching out to folks that were interested, started getting them to committees, because I don't think they had, like, if you're at a Mayo, you've got probably somebody on that's higher up the structure that can say, oh, Chadi, you should join this committee, and I know the call to make. But what if you're in the community? You may not have that connection. So I've been trying to bring those people in, assign them to committees. We started a community task force, and we meet now regularly, and that's grown. And that's really a great two-way exchange, because I really hear from the front lines of medicine what's happening in a radiation oncology clinic and where their pain points are. And that's directly impacting our board making, our decision making at the board. So these are just starts. And every session that we're having at ASTRO, I've asked, when possible, we need to apply this to a community practice setting.
Right.
Like no more of these. I mean, we're going to have a few that are just basic science, all, at a very high, you're talking about heat maps and everything else. But for the most part, like, even we have our first session on circulating tumor DNA, cell-free RNA, next generation sequencing. We're putting it in the practical radiation oncology session. And I've told our experts, hey, make sure that this is applicable. Why does our member who's going to go to their practice on Monday. Why do they care? And so that's kind of the challenge we're putting out is let's make everything accessible for frontline patient care.
It's hard to have someone of your caliber on the show not to ask about some controversial
Yeah.
topics in radiation oncology, at least controversial in my view. And I've done a lot of episodes actually. I've hosted many of your colleagues.
Mhm.
Prior presidents of ASTRO have come on my show. Ralph Weisigbaum came on my
Yeah.
show as well. I
Oh,
mean,
yeah.
you already know
He's got some
Ralph, right?
opinions.
He is unfiltered, right? And so he's very
He's unfiltered.
fitting for Healthcare Unfiltered. So I was thinking of four topics I would like you
Yeah.
like more to comment on, and one is proton therapy.
Yeah.
I know you mentioned you have a passion for this or you're interested in that.
Mm.
Proton therapy has its share of controversial topics. It's not very unusual to have two people on a podium in any type of meeting debating proton versus photon therapy. And I think I don't want to put words in your mouth, but it stems from the fact there are many folks who just say simply there are no studies that have demonstrated proton therapy to be superior or cost effective or blah, blah.
Mm.
Where do you stand? How do you respond to this? Is proton therapy ready for prime time? Is it still in select cases? Give us the cliff notes on proton therapy as viewed by Dr. Samir Keole.
Um, it's interesting. I get asked by different hospital systems to basically give my views, and so I always start with I'll ask you, Chadi, do you know how you make $50 million doing proton therapy?
I'd love to. If you tell me how, I'll do it right now.
You start with 100. So
Oh, I
I
see.
was
I
I
see.
tell me protons are a tough business, and so if you're getting into it for the business, it's that's you're probably thinking about it wrong. Um, I've learned a lot. My views on proton therapy have morphed a lot in the last 20 years, but that's how long I've been doing this. So it's very interesting. I would say if you've seen one proton system, you've seen one proton system. And one thing I think the proton therapy community hasn't been always as honest as it could be is there's quite a bit of heterogeneity between different proton therapy systems. And this has to do with the spot size and penumbra and a lot of things that we really would be mind numbing for the listener. But there is just a lot of heterogeneity between proton systems. And I'm not sure everyone in the proton therapy community realizes it. And I'm sure the general community does not. And so that I think has really been a challenge. And then the second issue is that the learning curve is pretty steep. The original MD Anderson randomized study on IMRT versus proton therapy for lung was very interesting in that it ended up being basically equivocal between the two arms. But the pneumonitis rate, and I don't remember all the numbers off the top of my head exactly, but these are pretty accurate, I think. The first year pneumonitis rates were like 35% or so. And the second year was like 13 or 15%. And the third year was 5%. So when you averaged out the 3 years, it came to be equivalent to the IMRT arm. But what you could see in protons is even at a world-class center of excellence like MD Anderson, they were in the learning curve as they were doing the study. And I think that's what I've seen over my time in proton therapy. I think protons have a role. I think I wrote a report for the National Health Service about 15 years ago. I think it formulated their referral policy. I think it's aged well. And I wrote on the low end, it's 5%. And on the high end, it's 40%. It's not the majority. It's not certainly 100%. It's not a photon replacement. Where protons really excel is large structures in complicated shapes. Example, we historically treated circles in circles, prostate, for instance. Prostate lends itself well when you had to build the complicated brass apertures, but now you'll be able to do spot scanning. So probably there's not a massive difference between a proton and an IMRT plan for a prostate only. But when you have to treat the pelvic lymph nodes, you reduce the small bowel dose by about 50 to 60%, the bladder dose by 40%, and the marrow dose by about 25 to 30%. Now, but in that probably is a lot more attractive, but actually that has not shown a clinical difference yet. So I do think there's certain cases, craniospinal radiation, again, which is rare, is I think much better delivered with protons. But I'd say if your lesion is under 5 centimeters and doesn't have geometric complexity, it's probably pretty equivalent between photons and protons. And so I think it's the responsibility of the user to make sure they're not a hammer and no patient is a nail.
Yeah, amazing and fascinating. My
Yeah,
next question
yeah,
is it's really more around, I mean, since you mentioned prostate, um, back in the day when, many urology groups started hiring radiation oncologists or even owning their
yeah,
own radiation oncology machine. And there were reports in the New York Times, Wall Street Journal, and so on, and you're familiar with that. But the idea behind it was that, suddenly the referrals to radiation oncology outside for prostate cancer went down. The number of prostatectomies, I guess, went down, and suddenly the urologists started doing the radiation oncology in their own clinic by hiring radiation oncologists. I wanted to wear on the Astro hat here. I mean, when you see something like this, I don't know, is there anything you could do? Is it just like, markets shifting and it is what it is? I mean, is this good for patients, bad for patients? I'm just trying to think from an Astro
mhm.
perspective, how do you handle scenario like this?
Yeah. That's a great question, and the horse has probably left the barn on that one. So there was for anyone who's interested in reading, there was a piece in the in the New England Journal of Medicine written by a woman named Jean Mitchell, who's probably one of the most well known healthcare economists in the country. It was probably published around 2012 or 2013, showing basically the pattern of referral by urology groups pre and post ownership.
Right.
And it was pretty stark. I think 33 out of 33 practices
Right.
it increased. It was no doubt it was a cause effect relationship. So we're torn here, right? At times, because look, radiation therapy is a great treatment for prostate cancer. So we don't want to say that. I mean, because it is. I mean, and we have randomized data that says it's equivalent to prostatectomy. I think it gets down, there's a loophole that people may not realize, and it's called the in office ancillary exemption. And the concept behind the in office ancillary exemption was services that are convenient for the patient should be exempt from Stark. Like if you go to see your primary care physician and they have a lab and they have and you need a chest X-ray, if you can get the chest X-ray done there, and if you can get the labs drawn in office, that's to your benefit. This is the patient's benefit. Somehow, radiology and radiation oncology services ended up on that list.
Yeah.
I still, it has never made sense to me because, you just don't put in a, $4 million radiation unit into your own building. Generally speaking, now these are complicated, arrangements made under the same tax ID to essentially monetize off the revenue stream from technical fees of radiation. So that wasn't, it probably, I didn't like it at the time. Astro took a strong position against it. It was unsuccessful because basically Astro was fighting almost the entire House of Medicine. So, Chetty, it's more, I think, an acceptance of this is now
Yeah.
people adapted. And so now you have integrated practices, and one could argue in
Right.
the end, was this better for patients? Because now you have more integrated practices. They didn't happen naturally. They happened really driven by the technical revenue of radiation therapy. So, like a lot of things, when you look back at it 15 years later, maybe we ended up in the right place. I still would love to see radiation therapy exempted from that list, but I don't think it'll happen.
How about my third question to you is AI and radiation oncology? What's happening that you gotta ask? I gotta ask about AI. I mean,
Yeah, I got to ask about
you
AI.
hear about AI about 700 times a day, so we gotta talk AI and radiation oncology.
It's amazing. This is a field that's pretty early on in artificial intelligence. And even there's things we've been doing called that are really artificial intelligence. We didn't call it artificial intelligence. So, a lot of what we do is we contour structures, right? We get a patient, we put them on a CT scanner and say, I've got to treat the pancreas. Well, I'm going to draw the liver, I'm going to draw the kidneys, I'm going to draw the bowel. And so one of the first things that came about was the ability to auto segment, as we call it, the liver and the kidney. So you didn't have to sit there for hours, or somebody didn't, a dosimetrist or physician didn't have to contour out the kidneys. You could just auto segment it based on Hounsfield units. And that was early days. Now we have training modules that are very good at reproducible anatomy, like the prostate. And so this is, I don't think we're going to see a replacement, but we're definitely going to see an augmentation. And I think right now, the average radiation oncologist in this country probably treats about 200 to 225 patients a year. That's a ballpark figure. I would not be surprised if that average radiation oncologist could treat 250 to 300 patients in 10 years. There still needs to be the human interaction, the empathy, seeing the patient, making decisions. That's never going to get replaced. But some of these other tasks, I think, can be augmented and sped up.
I gotta tell you though, but what excites me, what I would like to see, what I
Yeah.
would like to see, so you guys get on and work on this, okay? Because that's what
Okay.
I would like to see. I think we all know that you could probably sometimes deliver less doses with chemo and radiation. We know that.
Yeah, sure.
And you could still maintain the efficacy and reduce toxicity. I mean, God knows how many doses of chemotherapy we gave because
Mhm.
we went to the MTD, right? I mean, we're gonna try
Yeah.
to kill
Right.
you until we don't kill you, and then we give you the dose below that. So, what would be nice to figure out a way where you can apply all of the information, clinical, genomics, NGS, all of that stuff, and then you can come up to this patient and say, well, naturally, I would have given you, let's say, I don't know, 60 gray or 45 gray, but you know what? We can actually get by with only 30 gray and you'll still be okay and will be no effect. I would like to see that in chemotherapy and radiation therapy.
Yeah. 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 And I think that's happening. I mean, we've been going in that direction with randomized trials anyway. But I think what you're really talking about is personalized medicine, or the N of one, right? So, if I walk into a clinic and I've got, a liver cancer of some hepatocellular histology, like, what is different about me versus any other patient walking in through the door? So I think as we get more information on omics, this is a big part of what I do at Mayo Clinic for Mayo Clinic Platform, right? We're trying to create,
Right.
we have these data sets where we're trying to look at how to individualize and personalize treatments for the individual patient. I don't know if that's coming, it's not coming today or tomorrow, but I do think in 5 to 10 years, we'll have much more individualized treatments.
What questions I should have asked you and I
Yeah.
just completely failed to ask you? I want to make sure we part ways with you, just giving us whatever message you'd like to give the listeners and viewers.
Oh, sure. I think that I think there's a lot of concern that the field of radiation oncology is dying. In fact, I've never been more optimistic about the field of radiation. 5 years ago, there was a lot of concern. Where will the job market go? And in fact, we had a dip in medical student applications for the field. We had quite a few unfilled positions. Um, well, you go if you fast forward to 2025, there were far more positions available than graduating residents to fill them. So I would say if you have medical students or residents that are watching this, the field of radiation is bright. I do think that, like anything, if we don't evolve, if we don't pivot a little bit, um, other people will define our future for us. So while external beam radiotherapy for cancer is going to be our bread and butter and our backbone for the foreseeable future, we need to start reimagining ourselves a little bit, rediscovering brachytherapy, making sure you have your authorized user status cleared so you can deliver radiopharmaceutical therapy to the appropriate patients. As we start to look at radiation therapy for non-malignant conditions, and things like tumor treating fields and histotripsy, which are well within our skill set, we should be looking to offer these to patients. So there's a lot of things we could be doing, but we're not because we've ridden this external beam radiation therapy horse for a long time. But I think it's we do have to look at evolving.
Dr. Samir Keole, thank you so much for coming on the show. I would love to have you again and bring you back and talk a little bit more clinical as well with you. It's just really wonderful to have you on. Congratulations on your tenure, everything you've accomplished this past year, and you continue to accomplish. And if there are any last words, we'd love to hear from you as I let you go back to doing your duties.
No, at the end of the day, we're all volunteers. We're volunteers, but we care about at Astro, and this is the same for ASCO and ASH. And I think we want to give back and leave the field in a better place than when we found it. And so, I really believe in organized medicine, and I know sometimes people don't see the change happening as fast as they'd like to, but at least from our end, I can say we listen. So if you're a radiation oncologist and you don't like the direction Astro is going in, reach out to me. I take every single phone call, whether or not I know it's going to be pleasant. I take it, and at least I explain our position to anybody who's interested in having a respectful dialogue.
And part of this is coming on the show and sharing your views with my viewers and listeners. Samir, thank you so much for coming on.
Thanks for having me.